Good evening, everyone. I welcome you all to our online teaching program for postgraduates in pathology. Today, we have a discussion on case-based approach.
She got the slides and she really did a lot of work for this. So thank you very much. So before we start on clonal approach to cytopenia, we must understand first what is cytopenia. Cytopenia definition has been harmonized by the new WHO classification of myeloid malignancies. It categorically states that to call something as anemia, the hemoglobin should be less than 13, should be less than 12 for females. If you're saying leukopenia, it's absolutely neutrophil count, which should be less than 1800. But for thrombocytopenia, the platelet count should be less than 150,000. So when you have a patient of low-grade myelodysplastic syndromes, I cannot emphasize enough that it is the peripheral blood film along with the CBC that is the first thing that a pathologist will see. It could be most likely it is at a primary level. It is unlikely that these patients will first go to hematologists. They go to general medicine people. They can go to hematologists. They can go to a variety of different people. And a CBC plus a peripheral blood film is asked. So 85% of patients of low-grade MDS present with anemia. Right? And if you see how their CBC, how their blood cells are, their macrocytic show anisocoagulophytosis and sometimes show basophilic stippling. 40% of cases show neutropenia, and we will see what some of these abnormalities look like, such as nuclear hypersegmentation, hypogranularity. And 40% of some patients also show thrombocytopenia. Although this article describes it, I really haven't appreciated platelet hypogranularity so far. And in about 15% of the cases, all of these features may predominate. So before you start diagnosing MDS, you must take a long deep breath and first say that is the cytopenia clinically explained. So most of the times when you say that a patient is suspected to have MDS or he has cytopenia, almost most of the times there is something that clinically explains the cytopenia. So you can have nutritional deficiency in the form of B12, folate, or copper deficiency that can cause megaloblastic anemia, giant band fans, metamyelocytes, myeloid hypersegmentation, and many of us are familiar with these features. You can also have autoimmune conditions. You can have viral infections, especially HIV. During the early days of the HIV epidemic, there was a whole series of papers which showed that HIV has features that mimic myelodysplastic syndrome. So it's a good idea to be aware about this. You can have cytokines. In India, we see patients who have been given Ayurvedic treatments, who have been given especially some amount of some drugs, or they can have toxins such as arsenic, which is a component of your Ayurvedic homeopathic medications, which can give rise to an MDS-like picture. And you can have stress responses which can resemble MDS. Now, so the most important thing is do not jump to the diagnosis of MDS. Common sense first. Examine CBC, peripheral blood film, talk to the treating physician, or you can talk to the patient and take detailed history. The diagnosis of MDS categorically requires a bone marrow examination, because on peripheral blood film you must remember that there is an entity known as aleukemic leukemia, where the patient's bone marrow will be leukemic, but the patient's blood film will show cytopenia, and you might misdiagnose this as MDS. So how long should a patient have cytopenia to say that this could be MDS? So a patient should have persistent cytopenia for at least 4 months in one of the following lineages, that is erythroid cell due to the platelets. The only way you can say that this is MDS with confidence is that if you have increase in blast, or if you get MDS-related cytogenetic abnormalities. And the important thing is that the cytopenia should not be explained by an exogenous factor or comorbid condition. For example, if you have renal failure or chronic liver disease, these patients also have cytopenia, but it does not mean that they have MDS. So the next question that one should ask is how much dysplasia is required to call it dysplasia? So the minimum threshold for defining dysplasia remains at 10%. So the minimum threshold for defining dysplasia remains at 10%. How is this criteria at 10% arrived at? It is largely arbitrary and derived by experts, but it is still the best threshold that people agree upon that will distinguish a reactive condition from a neoplastic condition, but it is still completely arbitrary. For megakaryocytes, if you see micromegakaryocytes, they are very, very pathognomic of megakaryocytic dysplasia. And if you see micromegakaryocytes, the cutoff is 10%. But if you are seeing other forms of megakaryocytic dysplasia, for example, nuclei that are completely separated apart, or increased budding, or dislocate forms of megakaryocytes, the threshold for calling something as dysmegakaryopoiesis needs to be higher at about 30 to 40%. So when do we say this megakaryopoiesis is present? So the sine qua non of calling something a micromegakaryocyte is to show that the megakaryocyte is really small in size. That is a cell size approximating with that of a largest promyelocyte. All right. Micromegakaryocytes are the most specific dysmegakaryopoietic features. This is a reference which shows you from where the statement is made. You can have micromegakaryocytes in this form. You can have dysmegakaryopoiesis in which the nuclei are eccentric like this, and there is also 5q syndrome, for which I'll be showing you the photos. And sometimes you can have these widely separated nuclei which also make it MDS. But these are present or proliferated in reactive conditions such as ITP and any chemotherapy related insult. So you must be careful to not call these as dysmegakaryopoiesis. Or if this is the only feature that you're seeing, then the 10% criteria is too less. It should be around 30 to 40%. When do we say dyserythropoiesis is present? There are largely the two forms of dyserythropoiesis. One, nuclear features in which there are nuclear alterations such as nuclear budding. You can have these irregular nuclear membrane-like forms. You can have asynchrony of nuclear or cytoplasmic maturation. So this should be a reticulocyte, but its nucleus is still persistent. Then you have cells that show this. You can see this here, or you can see this here. These are megaloblastoid maturation. They are present in MDS, especially low-grade MDS, but they are alone not specific enough to diagnose this as MDS. Cytoplasmic features include the formation of ring cytoblasts, and in some cases you can have vacuolation. There is also internuclear bridging, which is also, and multinuclearity, which are signs of erythroid dysplasia. When do we say dysmyelopoiesis is present? Dysmyelopoiesis or dysgranulopoiesis has features of nuclear hyposegmentation. So typical nuclei for a neutrophil are trilobes. So you can get get cells which are bilobed like this, which is the pseudo-Pelger-Hewitt anomaly. So these are the Pince-Nez spectacles. If you've seen it, you know it. You can Google it otherwise. These Pince-Nez kind of morphology. You can also get commonly these pseudo-Pelger-Hewitt cells, which are completely hypogranular, as you can see here. You can have ring neutrophils, you can have abnormally high granules, and you can get these Pelgeroid forms in which these nuclei are now hyposegmented or completely round and small, or you can have extremely hypersegmented nuclei such as these. Okay, so all of these are suggestive of dysmyelopoiesis. So unfortunately, the diagnosis of MDS is subjective, and it is not easy. When I say subjective, it does require a bit of experience to call something as MDS, but thankfully you can ask for several investigations to help you reach that diagnosis. But it is important to note that evaluation of morphology is of critical importance, because if the morphology is not seen properly, then you are going to miss the diagnosis of MDS. So what should the investigations be done in case of MDS? First is a 5-part differential, preferably with reticulocyte count, then a bone marrow aspirate with iron stain, and if you have the expertise or lab has expertise to perform flow cytometry for MDS, a bone marrow biopsy, conventional karyotyping, which is very important, or if not that, FISH, and an NGS myeloid panel. So what I will talk very briefly about cytogenetics. I'm not a cytogeneticist, so this is largely theory talk. So chromosomal abnormalities are really common in MDS. These include a loss of genetic material such as deletions and monosomies, loss of chromosomal material such as monosomy 5 or deletion 5q, monosomy 7, monosomy 18, 20, or deletion of the sex chromosome such as Y chromosome are very common in MDS. You can also, unlike AML, balanced structural abnormalities such as translocation, for example, 821, or inversion, or translocation 922 are really uncommon in MDS. Inversions also are very rare. When you have 3 or more independent cytogenetic abnormalities, this is considered as a complex karyotype, and universally this is a poor prognostic sign. The major problem with conventional karyotyping is that metaphases fail, and MDS and cytogenetics can only provide an answer in a limited number of cases. So for MDS diagnosis, cytogenetics helps all the time, and only about 30 to 40% of the time. This is a data from a large German group. I think this is the MLL lab, which showed 914 patients, and even in such a large cohort or a very standardized cytogenetics lab, you can see that only 30% of the patients had abnormal cytogenetics. So therefore, cytogenetics is not perfect, and you require additional investigations to help get those abnormalities. So this is one of the largest MDS data sets, which showed the frequency of cytogenetics abnormalities in MDS. So in this data set, nearly 40 to 50% of patients of MDS found an abnormal karyotype. The commonest abnormality you see in MDS is isolated deletion 5q. When you say deletion 5q, at some times it can be accompanied by another cytogenetic abnormality, but more than one cytogenetic abnormality is problematic. This is followed by 7q and trisomy 8. So when you say deletion 5q, chromosomal 5q deletions are one of the most frequent changes, as I said, in MDS. The abnormality can be seen in low-grade MDS as well as high-grade MDS. Now, it is important to note that the location of 5q deletion matters. The deletions have variable breakpoints between 5q12 to 5q34. Typically, the MDS ones are at 5q31 to 5q34, which are the sub-banding that is present here. The ones that are present towards the centromere, so this is the centromere of the chromosome. The ones that are present towards the center are poor prognosis. They are more likely to be complex and high-risk MDS. Whereas the later ones are the so-called good-risk MDS, which can be treated with specific agents such as lenalidomide. So when you say MDS with low blast and 5q deletion, this is a distinct WHO entity. This is a photograph from the ASH image bank, which shows how these cells look like. They have this very characteristic unilobate morphology with eccentric nuclei or hypolobate megakaryocytes. They present in older women with macrocytosis and thrombocytosis. And if any, they can have one additional abnormality. Except 7q, if they have any additional abnormality, they cannot be placed. If they have 7q, they cannot be placed in this entity. One more additional chromosomal abnormality can be present. More than that is not present. What is important is that they can be treated with lenalidomide, and this is one of the best forms of MDS in terms of outcome. So why is cytogenetics important? Is because the natural history of MDS is that these patients actually go on to develop AML. So if you have a patient with monosomy 7 or a complex karyotype, these patients will rapidly go on to form MDS. If you have isochromy, if you have 5q deletion with trisomy 8, there can be a slow increase to MDS. If you have the isolated 5q deletion, these patients have the slowest transformation to MDS. But the minute they get additional chromosomal abnormalities, these patients then progress rapidly. Normal karyotype patients also progress slowly. Okay, so in the olden times, you had an IPSS, or a few years ago, you had an IPSS classification which looked at various factors, including cytogenetics, to risk stratify these patients. This was then superseded by the IPSS-R, or the revised IPSS classification, which based on these abnormalities classified these cytogenetic entities into 5 different categories, all of which had diverse outcomes. When do we use flow cytometry in MDS? I will be speaking and I will be showing cases with flow cytometry abnormalities, but it is still not a WHO 22 recommendation. It is useful if positive, but if negative, it does not mean so much, because essentially flow cytometry can only look at myeloid and monocytic lineage. It can look at erythroid lineage, but it has less specificity. But there is no way as of yet to evaluate megakaryocytic cells. You can have a variety of abnormalities, especially if they are present in blasts, which are CD34 positive or 117 positive. You can have a decrease in hematogones. You can have abnormal expression in intensity of 34 or 117, abnormal granularity, overexpression of 1333 or DR, expression of aberrant antigens such as 57, 1956, and expression of granulocytic or mature antigens such as 11B and 15. Sometimes erythroid cells are also abnormal, such as they can show decreased expression of 71 or 36. You can have abnormal numbers of 107 or 105 positive erythroid precursors. You can have abnormal granularity in neutrophils, or they can show abnormal or asynchronous expression of 11B, 13, 33, 16, or lack of 10. They can show aberrant 56 or 7. And monocytes too can show abnormal intensities or expression of antigens. We'll be seeing examples of all of these. In today's era, the WHO classifies MDS according to 2 entities. One, MDS, which is defined by genetics, in which you have either cytogenetics, for example, MDS with low blast and isolated 5q, or MDS defined by next generation sequencing, which is MDS with low blast and SF3B1, or MDS with TP50 biallelic TP53 inactivation, which is defined by cytogenetics or and NGS, and copy number analysis. You can also have MDS, which is morphologically defined, which is MDS with low blast, MDS that is hypoplastic, and MDS with increased blast, which is IV1, IV2, or MDS with fibrosis. So with that, I would like to start discussing the first case. I would like to request this first student to speak about this case.
Sir, I'm Dr. Devaditya, second year postgraduate resident from IGNS Patna. So the first case, sir, is a 67-year-old male with diabetes mellitus, complaining of weakness, and there is no organomegaly. So this is a picture showing the CBC findings. And
so just a second. So amongst all of this, what is the most important thing to note here?
So the first thing is that the age of the patient, it's an elderly patient, 67-year-old. Next, patient is a male patient. The patient is complaining of weakness, so there could be anemia could be there, and also the patient is not having organomegaly, so there's no splenomegaly, it's not there. Also, there is.
What does that tell you? If there is no splenomegaly or if there is no hepatomegaly, what does that mean?
Sir, it means that, sir.
Let me ask you in another way. If he had organomegaly, what would be the differential diagnosis here? Means if you have somebody with splenomegaly in a hematological condition, why do you think the spleen enlarges?
So you could be having a hemolytic anemia. So
you could be having a hemolytic anemia. Is that what you said?
Yes, sir.
Okay, so one is right. Why do hemolytic anemias have splenomegaly?
So because of sequestration of the RBCs.
Okay, so one is sequestration and increased production that is there. So one is that. The other things are, it could be myeloproliferative neoplasms, which is also, these are sites of organomegaly. It could be infiltration by lymphomas. So all of these can at times present with cytopenias. Like, you can have myelofibrosis, which presents with cytopenias, or you can have just hypersplenism or secondary causes such as liver diseases, portal hypertension, all of which give rise to non-cirrhotic portal fibrosis, all of which give rise to splenomegaly and cytopenia. So first thing that you should know in a patient of cytopenia is there organomegaly or not? It is one of the most important questions to ask. All right, let's go with this.
So next, looking at the CBC picture, so this patient is having pancytopenia, persistent pancytopenia for a period of more than 4 months duration. If you look at the hemoglobin is less than 13 gram per DL.
Don't read the CBC. Read the last thing as what is low. So I will say that he's got anemia, and that way.
He has got anemia. The absolute neutrophil count is also less than 1,800, and platelet count is also less than 1,50,000.
So he's pancytopenic. All right.
Yes, sir.
Okay. So what do you see here?
This is a bone marrow aspirate, which is cellular and aparticulate.
Okay.
And I can see, sir, a few megakaryocytes.
Okay. And at this power, there possibly there isn't anything abnormal about them. Right. So moving on to this, what do you see here? Let's start from a counterclockwise direction from top left. So Depender, yeah. Devaditya, sorry. Can you please tell me what we are seeing here? Do you think there are any abnormalities here, or what kind of abnormalities they are?
Yes, sir. I'm seeing a few megakaryocytes, which are micromegakaryocytes and non-lobated.
Can you please tell me where you are seeing the micromegakaryocytes? Is it so? This is panel 1, panel 2, panel 3, panel 4. Can you tell me where there are these micromegakaryocytes?
So I'm seeing it in panel 3.
Panel 3. So you mean here? Okay. So
no, sir. Sorry, perhaps panel 4.
Panel 4. So do you think this is a micromegakaryocyte? Is that what you were alluding to? Is this a micromegakaryocyte?
Yes, sir.
So this is a normal myeloid cell, okay? This is a promyelocyte. See, the nucleus in megakaryocyte is very darkly staining, okay? So, and plus it is really large in size. So this is not a micromegakaryocyte. Actually, this is there is nothing wrong with this slide. I don't see any hematological abnormality. These are all normal myeloid cells. There is some amount of megaloblastoid, erythroid change here, but other than that, I don't see any abnormality. All right, so it's all hunky dory. It's just normal. Okay, so this is normal spectrum of myeloid maturation. Okay, what do you see here?
This one, so the first slide is showing a picture of a micromegakaryocyte. Okay. The non-lobated nuclei and hypogranular.
Okay.
The second slide is showing a picture of an erythroid series cell, which is having a mild megaloblastoid change.
Okay, I agree. This is megaloblastoid change. This is sieve-like chromatin. All right, you see sieve, no chani or whatever you use to filter out atta. So it looks really like this. And what do you see here?
So over here you can see few.
Okay, let's be specific. What do you think this is?
So this is a micromegakaryocyte with.
So this is an abnormal dysplastic megakaryocyte. It's possibly a micromegakaryocyte, but it's not two nuclei. But that's okay. It is abnormal, and the important thing to recognize it as is abnormal. The blast count you must note, and the blast count is
3%.
Is less than 5%. Okay.
Less than 5%.
All right. So now I'm going to invite someone from the hematopathology lab. So who's going to speak on the floor for this case?
Astha.
Hi, Astha. Please go on.
So first we have our 45 versus site scatter, where we distinguish our different population. So the 45 bright and below site scatters are lymphocytes, which are in the blue color.
Okay.
Then we have a 45 bright with a little high side scatter are the monocytes, which are in the purple color.
Okay.
Then we have a 45 dim portion, which is 45 dim and high side scatter are the granulocytes. The fluorescent green color basically shows the mature granulocytes. Then we have 45 dim plot with low side scatter is the progen area, and where the myeloid blasts lie. So the red population here are the myeloid blasts.
Can I ask you what is this gray population likely to be?
So, these 45 dim can be our hematogones.
Okay, so hematogones typically lie here. All right, they will not have so much side scatter. Hematogones will lie here. What do you think this is?
So these can be our immature erythroids.
So they're just erythroid precursors, all right? You're right. They're erythroid precursors. Okay. So you can have erythroid precursors here. You also can have plasma cells which are present in the 45 blast gate or so on. As you can see that these erythroids are going all the way down as they are mature. Okay. So moving on. What do you see here?
Then there is next plot, which is basically the progen area. We have dated 34 with respect to DR. We can see the myeloid blasts, which are both 34 and DR positive, and as they mature towards the granulocytic lineage, they lose both CD34 and DR. Then in this next plot, we have 34.
So I'm just going to show this for the rest of the audience. What she's saying is that these are blasts, and as they mature, they go on in this direction till they start losing 34 and HLA-DR. They are then only HLA-DR positive, and as they mature towards granulocytes, they lose this DR as well. All right, moving.
Similarly, with respect to 34 and 117, the myeloid blasts are both 34 and 117 positive, and in the similar manner, when they differentiate towards the granulocytic lineage and mature, they lose 117 and 34.
Okay, all right. And here, what do we see?
In this grid, we have gated up progen cells, and with respect to 13 and 34, the myeloid blast, as they mature, they are gaining 13 and losing 34.
Okay, so as they mature towards monocytes, they go this way. As they mature towards granulocytes, they go this way. And then a portion of them don't have 34 at all. These are presumably hematopoiets. Okay, and here, what do we see?
Then we have 34 versus 38. The population, which is basically 38 dim to negative and 34 positive, are stem cells, which they differentiate into myeloid blasts, which are both 34 and 38 positive. And on further maturation towards the granulocytes, they lose the 34 and eventually also lose 38.
Okay, all right. So let's move on to the next slide. What do we see here?
Now these are the different maturation patterns of granulocytes. So we see in the first plot that CD13 versus 11B. The CD13 bright positive and 11B negative are pro-myelocytes, and as they mature towards the myelocytes, they begin to lose 13 and are negative for 11B. Then on further maturation towards the myelocyte, they are 13 negative and 11B positive. And then further maturation towards the band forms and the neutrophils, they gain both 13 and 11B.
She's talking of maturation that progresses in this manner. All right, so it's a U-shaped manner of maturation. And what do we see here?
In this plot, 13 versus 16, the normal maturation patterns is that from the pro-myelocytes, the 13 is bright positive, and then they begin to lose 13, followed by as they mature, they gain both 13 and 16. But in this plot, there is clustering seen at 13 and 16 negative area, which indicates that there might be a left shift in granulocytic lineage. Then we have 11B versus DR, which shows the granulocytes, as they mature, they begin to lose DR and gain 11B.
And what you see here is that this 13-16 negative cluster shows up as a cluster here. So these are your pro-myelocytes and myelocytes which are present here, all right? And these are your mature forms. Okay, so based on this, what do you think the flow cytometry is? Is it normal or abnormal?
It's normal with and there is only a left shift which is seen in the granulocytic lineage.
Very good. So for this patient, now going back to our friend, the student. So can you read the cytogenetics for this?
So fluorescent in situ hybridization, it is negative for deletion long arm of 20, monosomy 5, negative for monosomy 5 or deletion 5q, negative for monosomy 7 or deletion of 7q, negative for
Which is negative, which is negative, all right? And conventional karyotyping, what does it show?
It's 46xy.
So this is normal or abnormal? Okay, so what do you get on NGS?
So NGS, we can see mutation in the gene DDX41, which is located on chromosome 5 at the genomic address, which is specified by the genomic.
You don't have to read any of the numbers. You just have to read these two, okay?
So the important point to note here is the variant allele frequency, which is more than 2%, that is 50.50 for DDX for one of the mutations, and also 3.71 for the other mutation. So both are significant, and also this one having more than 10% means it's even higher risk of progression towards myelodysplastic syndrome. And
so to summarize the NGS findings, you have two mutations. These mutations are single nucleotide variations. So you can see C is changing to T, C is changing to T. So they are SND kind of mutations. They are in the same gene. One is at a low VAF of 3.71, one is at a high VAF of 50%. And these are associated, both of them are either pathogenic or likely pathogenic. So what do you think is the hematopathology diagnosis?
The diagnosis is possibly clonal cytopenia of undetermined significance.
Hematopathology diagnosis is inconclusive here, all right? That the NGS result is telling you that this could be.
Yes, sir. Yes. Clonal cytopenia. Yes, sir.
So what do you think? So you're saying that this patient has clonal cytopenia of undetermined significance, but we saw dysmegakaryosis. Then why you're saying that he's not MDS?
So because it is less than 10%. First of all, sir, I could see only one megakaryocyte.
So the main problem is that he's not meeting the criteria for MDS. So in the olden period to the WHO, the 22, there was a category known as IDUS, or idiopathic dysplasia of uncertain significance, which was where if you had a mutation and dysplasia not meeting the MDS lineage, you could call it as IDUS. So what do you think is the importance of this diagnosis? And what advice would you like to give to the patient?
So the importance of this diagnosis is that this clonal cytopenia of undetermined significance, it is a pre-leukemic conditions, and there is a chance of the high risk of the patient to progress to myelodysplastic syndrome and develop acute myeloid leukemia. So there's a 80% chance for him to progress within 5 years. So I would advise him to your follow-up and follow up with blood.
Okay. So when you see a DDX41 mutation, is there any other advice you want to give the patient? So one is you've told him that please follow up regularly. Okay, all right, I'll tell him to follow up regularly. But he's 60-year-old. Anything else?
So also DDX.
Okay, no worries. So we'll go on to what is happening here. So all right. So as a person starts to age, his these hematopoietic stem cells acquire somatic mutations, and the reason they acquire it is to get a fitness advantage so that they can proliferate easily, all right, and maintain hematopoiesis. So sometimes they say that these can originate even in early life, all right, but typically they're seen in their 40s, 50s, and 60s, and eventually everybody has clonal hematopoiesis. There are some additional things like external stressors, and we will see what these stressors are that give an proliferative advantage to these till these clonal hematopoietic clones evolve, and then the patient can get symptomatic in some fraction of patients. But essentially, as a person starts to age, these clones, see, this is an old guy, this is a baby. So in babies, you can't detect them, but in older people, these clones start to expand, all right? And they can be detected with sensitive things. So as a person starts to age, these mutations take place. These are mutations in these very specific genes, such as DNMT3, ATET2, ASXL1, and a variety of them at low VAFs of 9 to 11%. But when the patient starts to be cytopenic, the number of mutations starts to increase, their VAF increases, and then eventually they become myelodysplastic syndromes, where they start to acquire dysplasia. The mutations increase in number as well as the type of mutations till they become AML. So this is something that you should be aware of. It's a natural history of clonal hematopoiesis and myelodysplastic syndrome. So there are these words that are used: what is clonal hematopoiesis, what is arch, and what is chip. All right. So clonal hematopoiesis is a clonal outgrowth of hematopoietic cells from affected stem or progenitor cells, regardless of cause or disease state. Arch is a broad term where clonal hematopoiesis is seen associated with aging, but the patient does not have cytopenia or hematologic disorder. He does not have any specific gene alteration or criteria that is there. It can be any mutation. But when you have a mutation at a VAF of more than 2% or more than 4% in X chromosome in males, with a myeloid malignancy associated gene, with the absence of cytopenia, it's called chip. So if you see a random mutation somewhere, you can't say that this is chip. But if you get mutation in any of these genes, then it is called as chip. Okay, so clonal hematopoiesis is a broad term. Arch is a more narrower term, and chip, you can say, is like a cousin of arch. So chip clones require additional driver mutants. The chip clones require additional cooperating mutations such as NPM1 for clonal expansion and leukemogenesis to occur. So in a hypothetical scenario, if you have a patient with persistent cytopenia, no dysplasia, no blasts, with normal cytogenetics, you can call it ICUS, or idiopathic cytopenia of undetermined significance. If these patients have a mutation, if you do NGS testing on them and you do not find any mutation, this is called as non-clonal ICUS. If a mutation is identified at these points, these are called as CCUS, or clonal cytopenia of undetermined significance. And as we discussed previously, you have non-clonal ICUS and you have CCUS. The clinical risk of transformation for them is low, as opposed to MDS, which there is a higher propensity to transform into AML. And why it is important to know this? So this is one of the most important papers and most important investigations for patients who have unproven cytopenias, like they have undetermined cytopenias. In those patients, they studied a large cohort of patients, and they found that if the patient was cytopenic and had one or more than one mutation, they had a high propensity to transform into MDS as opposed to patients who were cytopenic and no mutation. All right. So therefore, it is important to do NGS in testing in patients who have unexplained cytopenia. But there is a very important thing that you did not touch upon: that this patient not only has a mutation, he has a mutation in a gene which is known to be associated with hereditary myeloid malignancies, namely DDX41. Okay. So if you see the classification of hematolymphoid neoplasms, you can see that there is this, that myeloid neoplasms with germline predisposition, with pre-existing platelet disorder, without pre-existing platelet disorder, or organ dysfunction. So one amongst them is germline DDX41P, that is pathogenic or likely pathogenic variant. So because you have a high VAF, likely pathogenic DDX41, you have to say that this patient needs to get tested for this, he needs to have his germline tissue that is to be tested. So this is a large cohort of 48 patients who had at least one DDX41 mutation. And you can see that out of these 48 patients, 33 of them had a coexisting germline mutation. So you can see that these are germline mutations of those patients, and it's around 75% of these 48 were likely germline. So you can see that almost always, or 70 to 60% of patients with DDX41 have two mutations. One is a germline mutation, and another is a second hit, which is a somatic mutation that you can see in our case. So they typically occur at high age of presentation, exactly like our case. This is a textbook presentation of a 60-year-old with cytopenia with DDX41 mutation. They present in 6th decade of life. They do not have any features which raise suspicion of the diagnosis, but these account for 3 to 4% of myelodysplastic syndromes. Half of the patients have also additional somatic mutation. Therefore, they're called as biallelic. We'll be seeing lots of biallelic today. They can have other mutations in TP53, AXSL1, and JAK2, and so on, and they can have 5q associated with them. So in this patient, the diagnosis is clonal cytopenia of unknown significance with possible DDX41 germline predisposition. All right? Okay, so let's go to the next case.
So in this case, there is a patient of squamous carcinoma of the cervix in July 2022 who received external beam radiation therapy to primary site and draining lymph nodes along with 3 cycles of concurrent cisplatin. Now she's presenting with persistent anemia and thrombocytopenia. On CPC, we can see that she's had persistent bicytopenia, but there is also leukocytosis. Here we are seeing a hypercellular marrow, and at this power it looks okay. Here on this power, we are seeing a few scattered megakaryocytes, and the inset shows a dyspoetic megakaryocyte with hypolocation and eccentric nucleus.
Why dyspoetic? Can you please tell me? Because I have taken hypology.
It looks hypolobated, and the nucleus is also very eccentric.
So megakaryocytes are large 3D structures. Okay, they're like big teddy bears, so they can form and they can fall over into any sizes and any kind of 3D structure. So this megakaryocyte to me looks just normal. It just looks fine. It's just a photograph to show you that this is a normal megakaryocyte. All right, and what do we see here?
Here, sir, we are seeing various myeloid cells, and they look pretty much okay.
Okay, do you think the color here is too red with a lot of granules?
Yes, sir.
Why? Where do you see color red with too many granules in myeloid cells? Let's think. You know the answer, I'm sure. So if a patient has infection, what do you get?
We get so dole bodies, like toxic.
You can get dole bodies, but you can get these toxic granules, like angry looking red cells, no? Here. Yes. So you can get that. But why is this patient having it? It doesn't have sepsis.
There's also leukocytosis.
Yeah, so there is some leukocytosis. He maybe have been given growth factors also. So when you give patients of cytopenia growth factors, you can sometimes start seeing changes like this. And this is some amount of megaloblastoid appearance, okay? Yes. Slight amount of megaloblastoid appearance. Now, let's ask our HemePath folks to help us with this flow cytometry.
Hello everyone, myself Dr. Sukriti. So I will be presenting the flow plots of this patient. So as explained by my colleague Dr. Astha, so we will separate our population with the help of CD45 and site scatter plot. Here we can see the CD45 moderate to bright population with the lowest site scatter are my lymphocytes, then CD45 moderate with the low site scatter are my monocytes, and the CD45 dim and with the highest site scatter they are my granulocytes. And this population, which is again CD45 dim and lowest site scatter, are my progenitor, where my blast resides. And as in a previous case we had erythroid series also, but we have just blast here. In next plot we can see CD34 versus CD38. In this again the CD38 dim and CD34 bright population is my stem cell, which are maturing towards my myeloid blast, which is again 34 and 38 moderate, and losing this they will be again maturing towards granulocytes. With the 34 in 117 plot, the clustering here again is indication that these are my myeloid blasts which are 117 positive and 34 moderate. 13 versus 34 plot is again normal maturation, where my myeloid blast again maturing towards the monocyte by gaining 13 and even towards the granulocytes. With the help of 13 and CD7, we are just looking any aberrant markers which can be present in my myeloid blast. So one of the aberrant marker is CD7. The CD7 is absent in my myeloid blast, which is again indication that there is no aberrant marker which is present in my myeloid blast. With the help of HLA-DR and CD117, again I can see this is my clustering, which is again normal for my myeloid blast. With the help of 13 and 16 plot, I'm just seeing that the 13 positive population and 16 negative is my promyelocytes. And as the granulocytes mature, they lose CD13 and they start gaining CD16. So this is my mature granulocyte, which will be again my band and neutrophils. And here I can see a little bit clustering, which is 13 and 16 negative. This is indication that it can be a left shift, or it can be since we have seen that neutrophils and myelocytes, metamyelocytes were increased. And in my next plot, where 11B and HLA-DR is there, again we can see that by losing HLA-DR, there is a gaining of 11B. Again, it is a normal maturation pattern which is seen in granulocyte. And with the help of 13 versus 11 plot, again there is a maturation pattern where 13 positive promyelocytes are maturing towards myelocyte and metamyelocyte. By losing 13, they are start gaining 11B and maturing towards neutrophils, which are 13 and 11B positive.
So to summarize the flow cytometry, are you seeing anything that is normal?
No, sir. There is no abnormality which is like seen in any kind of my myeloid blasts were normal and my granulocytes are normal.
All right. So I apologize if you can get it now. So would you like to continue reading the cytogenetics for this patient?
Yes, sir. Yes.
The students.
So here we are saying that the fish is negative and karyotyping is normal.
So karyotype is normal. Very good. All right. So NGS findings. Would you like to read out the NGS findings?
Yes, sir. On NGS we have seen
Go ahead.
a truncated mutation of TPM1D gene with a VAP of 5.74%, and it is pathogenic.
All right. So you're seeing a mutation here. Do you think this is a point mutation or this is an indel? Okay. So a G is changing to a A at this particular nucleic acid. So what kind of mutation is this?
So it is a point mutation.
It's a point mutation. And if you read the protein sequence there, what do you think is happening?
It's turning into a stop codon.
Very good. So you have a stop codon being gained here at a variant allele frequency of 5%. So what is the hematpad diagnosis and how does the NGS change anything? And what is the importance of this diagnosis?
The hematpad diagnosis based on the Morton flow would be hypercellular bone marrow, according to me. But then if you take the clinical context and the NGS into consideration, it can be myeloid neoplasm post cytotoxic therapy.
Very good. So if you look at the hematopathology diagnosis, we really aren't going anywhere. We are having an inconclusive diagnosis here because the patient has got cytopenia, but nothing else that we can show more than that. All right. And the NGS provides you with a PPM1D mutation. Does that mean anything?
So TPM1D mutation is a significant mutation, especially after cytotoxic therapy, and in cases which have been treated with cisplatin, about 15% of cases can show this mutation. And
very good. Excellent. So you're right. All right. So let's just talk about a little bit more about some advanced things in clonal hematopoiesis. So clonal hematopoiesis is associated with adverse health outcomes through a different variety of diverse mechanisms. So if you have TET2 mutations in CHIP, they're typically associated with inflammatory state in the body, and they can lead to accelerated atherosclerosis. So these patients are more likely to have heart attacks. All right. If you have patients with JAK2 mutations, they release something called neutrophil extracellular traps, and they result in thrombi, and these can result in thrombogenesis. And if you have, so these are two ways in which you can have complications such as atherosclerosis and thrombosis with different types of CHIP. So there is also something else that most patients, their clonal hematopoiesis stays stable for decades. Either when you have inflammatory stress or you have some cytotoxic stress, there are associated cardiovascular abnormalities or therapy-related myeloid malignancies. So there actually is a latent or a therapeutic window which offers an opportunity in which you can intervene. All right. So this is a fantastic paper from the Sloan Kettering from MSKCC, which showed almost 24,000 patients with blood cancers, around 30% of whom had clonal hematopoiesis. And these were patients exposed to a wide range of therapies such as cancer therapy, cytotoxic therapy, radiation therapy, targeted therapy, immunotherapy. And they found that DNMT3, TET2, PPMD1, ASXL1 mutations were most common. So these mutations were distributed uniformly all across the different cancer groups, except that, as Mitali said, that except in patients of ovarian and endometrial cancers, you had a strikingly increased predisposition of these PPM1D mutations. In fact, when you saw how these patients were associated with progression, only 3 genes stand out. That is, patients with CHEK2, PPM1D, or TP53 mutations were more likely to transform into MDS or get into a cytopenic state. Similarly, ASXL1 mutations were associated with smoking. So radiation therapy and cytotoxic therapy, exactly what our patients had, were significantly associated with clonal hematopoiesis. Regimens containing platinum and topoisomerase 2 are strongly correlated with DDR pathway, which is DNA damage repair pathway, including mutations in TP53, PPM1D, and CHEK2. All right. So these mutations give the clonal hematopoiesis clones competitive fitness so that they can grow faster. So this diagnosis is therapy-related clonal cytopenia of unknown significance with PPM1D mutation. Okay. So going on to third case. So may I request the third person to speak, please?
Yes, sir. A 14-year-old girl, transfusion-dependent anemia with easy fatigability since the age of 9 years. Diagnosed to have idiopathic immune thrombocytopenia since 2017. No lymphadenopathy, no organomegaly. The investigation shows anemia and thrombocytopenia.
Okay, all right. So she's got anemia and thrombocytopenia. She's a young girl of 14 years old who has got this longest history of thrombocytopenia since last 5 years. So what are we seeing here?
The bone marrow rate shows hypocellular marrow fragment with cellular trails.
So hypercellular, I would say, not really hypocellular. This looks okay to me. All right. Okay. So here, what are we seeing? I think there's a megakaryocyte, and overall it looks the same thing. It looks cellular. Okay.
Sir, there is audio-video asynchrony.
There is asynchrony in what? Audio and video. Is that what you said?
Yes, sir.
Is everybody else hearing properly?
It's fine. It's going on well.
Okay. All right. Okay. All right. So what do we see here now in this picture? What do we see?
So now I'm seeing the first image which shows the hypolobated, unilobated megakaryocyte.
So there is an abnormally unilobated megakaryocyte with eccentric nucleus here. And what do we see here?
Subset image.
Sorry, I really cannot hear you, Anjali. Okay, who's the flow person who's supposed to speak on this? Priyanka, is that you?
Yes, sir.
Okay, okay, Anjali, we'll try once again, but if the audio is sketchy, we'll just ask somebody else to take over the
So I
session.
can listen to it, but there is audio video synchrony. I cannot see the slide you are saying.
Such a shame. So maybe we can ask Dr. Priyanka to please take over the description of this case.
Sir, I can speak with according to the slides that I have. Okay. So case
But the
3, the
problem is
slide.
that I may have added some additional slides. So I think best Priyanka speaks.
Okay, sir.
All right, Priyanka, from top left.
The slide in the upper left side, they are predominantly showing there are shift to left cells. Like here is a two myelocytes, then one neutrophil is there, which looks bilobed, would be the pseudopelvic uva cell. In the upper left side, we have this erythroid colonies with shift to left erythroid series. There are few neutrophils seen, and one I can see two blast here.
So there are maybe some blast-like cells here, and there are some megaloblastoid erythroid colonies here, and there is some abnormal nuclear maturation here. Maybe not best to over-interpret this. This really looks normal to me. I'm not so sure about pseudopelvic here. There really does not seem to be any dysplasia here. What do we see here?
In the third slice, we have
Yes.
a binucleate erythroid cell.
So there is binucleate erythroid cell, some amount of megaloblastoid change, also nucleocytoplasmic asynchrony here, and so there appears to be some subtle dyserythropoiesis going on. What is this?
So it's a pro-normoblast.
Correct. And do you think its morphology is normal or it's slightly megaloblastoid?
Like all the erythroids are showing megaloblastic change.
Megaloblastoid. So they are showing megaloblastoid change here especially, and you are having these binucleate fellows here. All right. So let's move on. And what do we see here?
So it's first, which is in the insect, is a neutrophil, which is bilobed and hypogranular as well.
So this is not really hypogranular, but you are getting to the right point that its nuclear segmentation appears abnormal, and it is called as a
Pseudo-Pelger Huey.
so pseudo-Pelger kind of changes there, but it's not really very hypogranular. It's okay, but it's getting there. You're right. And what do we see here?
These are the erythropoietic erythroid cells. Here in one cell, the nucleus is very irregular with asynchronized like cytoplasmic to nucleus.
So this is irregular nuclear margin, all right? And this seems to be nuclear. So all of these features we see in the books, we read about them. So this is what it means. Okay. So all right. So this is your forte. Now let's quickly summarize the plots what we see here. So I will help you understand what's going on for benefit of everybody. First, describe what we see here, and in comparison is the normal. So this will help everyone compare. So the corresponding plots of normal, normal is to abnormal. So tell me what's happening.
So first I'll describe the normal plot. Here the Progen 2 area.
So which plot are you describing? The CD34 versus 38?
The normal, the 34 versus 38 plot. Here as we can see, there is the 34 positive and 38 negative population is our stem cell. Then it progresses ahead, gains 38, and slightly then again with the further maturation, the 34 is the 34. I'm not getting the word.
It's losing its CD34.
It starts gaining 38 and further
it's progressively increasing in 38, and then both are being lost. All right. So what do we see here?
So in the above, in this case, here we are not seeing that maturation pattern. Here the blasts are homogeneously positive for CD34 and 38. There is clustering, we call it. There's no maturation with respect to 34 and 38.
Also, there is some loss of intensity of CD34 here as compared to these blasts. It's slightly higher at the center here, and here the center is almost at half of 10 to the power 1. So some mild decrease in CD34 intensity. Same thing we are seeing here. And what we are seeing here, CD34 versus 13.
So in in the case, the normal one, 13 versus 34 is showing a progressive pattern. Like 13 is positive, but in our case, 13 is brightly expressed as compared to the normal.
And also there is an abnormal cluster there, all right? So there are definitely some maturational abnormalities that we are seeing here. And what we see here?
So normally we have a CD117 and 34 positivity, and the pattern is here what we have gated. So in our case, the 117 is brightly expressed, and it is clustered with respect to 34 and 117.
Right. So there seems to be that there is some abnormal blastic maturation. So what do we see in these plots? Quickly describe any abnormalities that you see in the granulocytic. So the green is granulocytic lineage cells.
So the green cells, these are our granulocytes. So with respect to 13 and 16, it is forming a nice maturation pattern as we expect Nike pattern. And here there is no overexpression of the HLA-DR. Even the 13 versus 11B pattern is very nice, forming a U-shaped pattern, which we expect. But there is one abnormality. The grands are abnormally expressing CD2 here.
So that is one abnormality. The grands express CD2. And what do we see here? These are monocytes, which are teal colored. All right. What do we see here?
So here, this 13 versus HLA-DR, subpopulation of mature monocytes are negative for CD13.
Okay, so this population is abnormal. And what do we see here? What do we see here? DR11B?
In DR11B, only a subset of monocytes are HLA-DR negative. Otherwise, the predominant mature monocytes are
It looks normal. All right. This is the normal pattern of maturation of DR11B. But there is some abnormality here. What is that?
So normally our maturation of the monocyte it follows like DR is dim, then it gains DR, then starts the DR, then slightly reduces, gains 14, and then a 14 bright and DR bright population is there. In this case, there is a population which is 14 negative predominantly.
So there is a population of monocytes or monocytoid cells, monocytes, which is HLA DR positive, 14 negative. All right. And cytogenetics, what does it show?
So in cytogenetics, it is negative for deletion 20q, monosomy 7. That is
so fish is normal, and there appears to be some derivative chromosomes which are present here. So there is some abnormality seen on cytogenetics. Okay. So maybe you can, Anjali, would you like to, can you speak on the NGS findings?
Yes, sir. The cytogenetic, the NGS shows 2 mutations at chromosome 21, gene next one.
So you don't have to say the chromosome. Just summarize here. So which gene it is?
They both are pathogenic.
Okay, so there are 2 mutations in RUNX1. Both are pathogenic, and both appear to occur at the same locus. All right. Okay, and both of them have different VACs. One is at 26%, and another is at 13%. So we decided to look slightly closer at the IGV plot here, and you can see that although this is the same codon, they're actually occurring on different DNA molecules. So each of these is an NGS read, this one gray row that you see here, and here you have a C2T change, and here you have a G2A change. So there are 2 different mutational clones which are present. So what is the hemat-path diagnosis? Anjali?
So my diagnosis was childhood MDS with low blast count.
Okay, so does the NGS result influence the diagnosis?
Sir, the mutation shown by NGS1 is associated with rapid progression,
Okay, so what you're saying is the mutation seen, that is RUNX1, is associated with a poor prognosis, associated with rapid progression. Right? Is that the only thing that is to be considered here? Is there any advice you would like to give the patient?
This mutation, so the patient need to further work karyotyping.
Karyotyping has already been done, so I don't know how additionally karyotyping is going to help you. All right, so let's go with what we are seeing here. All right, so you're right. This is a case of childhood MDS with low blast. It is a myeloid neoplasm defined by cytopenia dysplasia in children less than 18, less than 5% blast, less than 2% blood cells. Clinical symptoms and morphology actually represent that, similar to that of adults, and patients represent dysplastic progression. So this is important thing to know. So one, they can appear to have progressed from inherited bone marrow failure syndromes, or they can have progression from germline predisposition syndrome such as RUNX1, ETV6, GATA2, SAMD9 or SAMDL9. And this other dysplastic features are similar to that, but what you would see in MDS. So in these patients, monosomy 7 is commonly seen. We are not seeing it. Essential criteria is that you should have dysplasia of 10%, blast should be less than 5, less than 2, and it means it should have clonal cytogenetic or molecular abnormality, and you should have excluded other causes of cytopenia. All right. So important thing to note here is that there is this patient is having a manifestation of hereditary myeloid malignancy syndrome. So if you see this patient, he's got persistent, long-standing thrombocytopenia of 5 years. He's been misdiagnosed to have ITP, and this is a typical abnormality that we see with myeloid neoplasms with germline predisposition and pre-existing platelet disorder. So 3 genes, if you see mutations in them, ANKRD26, RUNX1 and ETV6, they can have lifelong thrombocytopenia, platelet dysfunction, and their risk of myeloid malignancy. So in this patient, there is most likely a germline RUNX1 with an additional somatic RUNX1 mutation that is there. So we are testing this patient and his relatives for the germline tissue by looking either. So in any of these patients, if you want to establish the diagnosis, one, you need to look at his remission sample. So that means if a patient has acute leukemia, treat with chemotherapy, and morphologically the blast is normal, that point you sample his blood, or you culture skin fibroblasts, or separate out T lymphocytes, or you look at hair root and nail clipping. So this is how you diagnose these disorders. Okay, they are detected by investigating the thrombocytopenia. There is a family history of cancer or known RUNX1 mutation in relative. You can also get them by somatic mutations by routine myeloid malignancy testing. So for example, you test for AML and suddenly you see RUNX1 at high VAF or TP53 at high VAF. Another way in which these can be suspected is like how we are seeing biallelic gene alteration. That means 2 pathogenic mutations in the same gene. Then they can involve one with a mutation or one with copy neutral LOH. And sometimes you can have very high VAF like homozygous mutation. And in such ways you can suspect these conditions. So the diagnosis is childhood MDS, low blast, possible germline RUNX1 mutation. Right. So let's move to the case 4.
So, 69-year-old male presenting with dyspnea on exertion and easy fatigability.
Okay.
Complete blood counts reveal pancytopenia, and the cytogenetics is normal.
Okay.
This is a bone marrow aspirate showing colonies of erythroid cells with megaloblastoid change, and 2 of the erythroid cells are showing a nuclear budding.
Okay, very good. And what do we see here?
Pulse stain is showing ring sideroblast and more than 18% of the cells.
Okay, all right. And quickly, let's go through the flow cytometry of this. So, who's going to speak on this? My colleagues from Flow Lab, where have they gone? Hemat Lab? Okay, all right. Himani, why don't you speak on this? What do you think is the flow cytometric abnormalities here?
Blasts are.
That's it. Okay, all right. Simply
We can see in these flow plots, first is 34 versus 38 plot. So we can see that the blast, that is marked in red, we can see the stem cell part, which is 38 dim to negative and 34 positive, and they are maturing. As they mature, they lose 34 and they gain 38.
So let's just quickly talk only of the abnormal things, because we have gone through the normal steps. So is there anything abnormal that you see here?
Not exactly, sir. Just that there is a partial expression of 13 in the myeloid blast that we can see.
Okay, all right. So you're right. So part of the blast appear to be negative for CD13. Other than that, it looks fine. This is not enough to say MDS, because even normally you'll have some cells that are clustered here. Okay. Is there anything abnormal that you're seeing here in granulocytic lineage?
Yes, sir. So the maturation pattern, that is 13 versus 16 and 13 versus 11 is a little abnormal. As we can see that they're bridging kind of a thing which is formed in 13 versus 16 plot. That shows that there is early maturation that is happening. It's a quick maturation that is happening.
Instead of a line like a U here, you're seeing a V. Is that what you mean to say?
Yes, sir.
Okay, all right. And anything else that you're seeing here?
So there is a little, there is CD10 loss in the mature granulocytes, but there is still a subset which is positive. And granulocytes are showing aberrancy, that is CD7 and 56 is coming positive in the granulocytes, which is not normally seen.
So 2 abnormalities here. Abnormal pattern of 13-16, partial loss of CD10 on mature granulocytes 3, sorry. And you have aberrant lymphoid expression, that is 756 on the granulocytes. Anything wrong with the monocytes?
So monocytes, there is this cluster of monocytes in 14 versus DR plot, which is showing loss of DR. So that is an abnormal.
Perfect. So instead of seeing monocytes like this, you are seeing a loss of HLA-DR or partial loss of HLA-DR on the monocytes. And on the erythroid cells, anything?
So there is an increase in the compartment of like erythroid precursors are increased. That is like normally it is 9%. If it's more than 9%, it is abnormal.
So not only that it is increased, the CD117105 positive fraction here is almost at 50%. And you can see that there is a fraction that is 117 negative, but more importantly, this fraction is really high. Okay, 105, 117 positive fraction. All right. So cytogenetics, is there anything?
No, sir. It is negative for.
It looks normal. And what do we see here?
So there is a missense mutation seen in the exon 14 SF3B1 gene, which tells us that this could be MDS with low blast and SF3B1 mutation.
Okay, all right. So we see an SF3B1 mutation. So what is the, so going back to our student, here, what do you think is the Hemat diagnosis here?
MDS with low blast count with ring sideroblast.
Okay. Is that the WHO term now? The WHO term is SF3B1 mutation, right?
SF3B1.
But you're right, it makes no difference. Okay. Does the NGS influence the result diagnosis or prognosis?
Yes, sir. So SF3B1 mutation has better prognosis. It is a low risk. It has low risk.
Fantastic. So SF3B1 mutations are very common in MDS. Most of them occur in the K666 hotspot of the gene, but can occur everywhere else as well. Importantly, these are associated. The only mutation in entire MDS lineage which is associated with favorable prognosis is SF3B1. So these mutations, especially when they occur isolation, are associated with a favorable prognosis. This has led to changes in the diagnostic criteria for MDS with ring sideroblast in NCCN guidelines. And now the WHO says that these patients can be called as MDS with low blast and SF3B1 mutation. they have most commonly present with anemia, less commonly with thrombocytopenia and neutropenia. So dysplastic features are only seen in erythroid lineage commonly, right? They have megaloblastoid, erythroid hyperplasia, and other dysplastic features are uncommon. So you get an increased proportion of proerythroblasts, and you can see iron ring sideroblasts when you do iron staining. So criteria for diagnosis is that there is cytopenia without thrombocytosis, erythroid dysplasia with blast detection of SF3B1, and if SF3B1 is not available, then ring sideroblast should be more than 15%, and they should not fulfill any of the other WHO criteria for other MDS lineage. So the diagnosis, as you rightly said, is MDS with low blast SF3B1 mutation. Case 5, who's going to talk on? Hi, please go on.
Thank you, sir. 61-year-old male with productive cough, weight loss, and loss of appetite. Routine CBC finding reveals pancytopenia. Hemoglobin 5.3, total count 3,800, and platelet count 73,000.
Okay, all right. And what do we see here?
Sir, this is a picture of pulmonary aspirate, and in the upper and left, and there is presence of these megakaryocytes in the form of monolobated megakaryocytes, and with presence of some lymphocyte, and right.
So you have an abnormal megakaryocyte here,
yes,
almost like a micromeg. And what do we see here?
Sir, here two separate nuclei of megakaryocyte, or maybe two fused monolobated megakaryocyte.
Normal appearing megakaryocytes here, and you have presence of
myeloblast.
there are blasts that you can see here. And what do we see here?
So there may be dysplastic granulocyte, possibly dysplastic neutrophils.
Perfect. So there are dysplastic, small-looking granulocytes, very mature-looking small granulocytes are seen here. And there is also some subtle dyserythropoiesis,
yes,
some more dysmegakaryopoiesis, and again those mature dysplastic neutrophils that you are seeing. All right.
Yes, sir.
This is the bone marrow biopsy. You can see that the biopsy is really cellular,
yes, sir.
and you have some of these abnormal megakaryocytes here.
Yes, sir.
Okay. And if you do glycophorin A, you can see that there is a lot of erythroid hyperplasia. All right.
Yes, sir.
Okay. So what do we see here? Who's going to talk on the flow findings here? Sneha, hi, go on.
So myself, Sneha, I'll be explaining about the plots of this case. Over here we can see the plot of our case, which is showing an increased amount of 45 DIM and low site scatter progen area, which is highlighted by the red color, which shows that there is an increase in the progen blast population compared to the other plot, and which shows which is a comparatively normal looking flow plot, which has a lower percentage of blast population.
There's another finding here, Sneha, that we would like to speak about. You see the lower boundary of granulocytes here, CD45?
Yes, sir.
As I explained before, that the blast population needs to be above this. So in normal case, you see this red population, these are myeloblasts. Their population is almost always above the lower limit of granulocytes. But in this, the CD45 for the blast population is lower as compared to that of granulocytes. And then it's in itself an abnormal finding that you should be aware of. There is loss of CD45 on the blast. In myeloid blasts, this is a very subtle finding. Okay, now what do we see here?
So in this, we can compare the case with the lower one, which was a normal case. So in 34 versus 38 plot, we can see that the blast population, first of all, it's having an increased amount, and it is not following the normal pattern, which is shown in 34 versus 38. And there is also downregulation of 38, which is almost dim to negative. And in 34 versus DR plot, also we can see that the normal maturation pattern is lost, and there is a moderate expression of DR clustering is present. In the 13 versus 34 plot, we can see that the blast population is showing a variable expression for 13, starting from 0 to 10 to the power 2. So it's having a variable expression which is not normally seen, and also there is increased amount of blast.
What do we see here?
In this, the granulocytic population is seen, which is following the 13 versus 16 pattern. When compared to the case 3, which was normal, there is a clustering in the immature granulocytes, and there is a gap in between. This shows that there is some amount of clustering left shift towards in the granulocytic state.
There is an abnormal pattern of maturation with respect to 13 versus 16, and DR11B, however, is normal, except for a fact that there is some retention of DR on the granulocytes. Okay, all right. So there is abnormal pattern of maturation of 13 versus 16. What do we see here?
So in the monocytic population, the 14 versus DR plot is showing a normal Z pattern, which is initially there is DR positive is there and 14 negative immature monos, which then start losing DR and gaining 40, and then as they mature, they gain both 14 and DR. So the monocyte.
The thing is that there is a large fraction of DR positive, 14 negative monocytes here. Okay, these are not chemotherapy induced, like these are not patients post induction. So you don't expect to see such a large proliferation of immature cells here, and that's what makes it abnormal. And also there is some variability in CD13 expression. Once again, it is not just one finding; it is all of this put together that makes it a diagnosis of MDS. Okay, and again, what we see here is some increase in pro-erythroid or early precursors for this.
So 117 positive and 117 stable and 105 positive fraction is coming approximately 18% of the population.
What does it show?
The cytogenetics positive for deletion 20, 20q, deletion 5q, deletion 7q, and TP53 mutation in 90% cell.
And NGS, what are we seeing?
Okay, TP53 mutated cell and variant allele frequency 52.10%, type of mutation non-synonymous single nucleotide variation, and which is pathogenic.
And this is a copy number variation plot, all right? So would you like to comment on what we are seeing here? This is known as a CNV analysis. So what do we see here? So I'll take you through it, no worries. So what we are seeing here is that these are probes of NGS which are present throughout the chromosome. So you can see that there is a deletion in your 17 chromosome that you are seeing here. All right. So you can see that there is a deletion in 17p. There is a monosomy of 7. There is a monosomy of chromosome 5, and there is a gain in chromosome 20, similar to what we are seeing on fish. But the monosomy 7, the deletion in 17 is important because now you have two abnormalities of chromosome 7. So what is the hematopathology diagnosis?
Sir, hematopathology diagnosis would be MDS with XL blast, XL2, and TP53 mutated at complex karyotype.
Okay, all right. So not quite right. All right. The diagnosis here is myelodysplastic syndrome with biallelic TP53 inactivation. It's okay. These are advanced cases, but it's just good idea to be aware of. You're right. On morphology, it is MDS RAB2, but it is something that is very unique. Okay, so this is now a distinct entity recognized by the WHO, all right, where you have biallelic TP53 inactivation. So let us understand a little bit by what this means. So the definition is a myeloid neoplasm with cytopenia dysplasia less than 20% blast with 2 or more TP53 mutations, 1 mutation or 1 copy concurrent copy loss, that means loss of what we saw as a deletion, or 1 mutation and 1 copy neutral loss of heterozygosity. So to understand this, you have to read this seminal paper published 2 years ago, which showed what is the implication of TP53 allelic state. So they looked at a large cohort of 378 patients, which were TP53 mutated out of 3,000 MDS patients. And they found that 11% had TP53 mutations, 72% of these mutations had just 1 TP53 mutation, but 27% 56% had an additional TP53 mutation or they could have had. So the way to define multi-allelic TP53 was either multiple mutations with no deletion or no loss of heterozygosity, single mutation with a deletion, like how we are seeing in our patient, or mutation with concurrent copy neutral loss of heterozygosity. Why it is important to know of this is because these patients have a dismal prognosis as compared to patients who have just one TP53 mutation. So if you have two TP53 mutations, these patients have a much inferior prognosis and a higher probability of transformation to AML as compared to the rest. So we go on to the last case. This is a 56-year-old with bicytopenia. Who's going to speak on this?
This will be me, sir. This patient is having a pancytopenia for 5 months duration.
Very good. And what do we see here?
For 56 years of age, he is having hypercellular marrow fragment and cell trails.
Right.
So the bone marrow aspirates, first slide shows dysplastic megakaryocyte with separated lobes of the nucleus. And the next one also I can see like 2-lobed megakaryocyte, dysplastic megakaryocyte.
And a micromegakaryocyte.
And yes.
What do we see here?
And, I can see large cells with dispersed nuclear chromatin resembling blast.
So lots of blasts and some megaloblastoid cells, and there are 14% blasts. All right. And on MDS, on flow, what do we see? So Mona, I think Mona can just summarize quickly what findings we are seeing, because we need to wind this case up.
Yeah, good evening, everyone. So in the first layer plot, as has been explained before, it's a 45 side scatter plot wherein we have basically distributed our population. Coming on to the plot here, which is 34 and 38. So we see two clusters. One which is highlighted in the red is our blast, which is positive for CD34 and dim to negative for 38. And the down below, the ones highlighted in green are our granulocytes, which is negative for CD34. And there is a small population in pink color, which is 35 bright, which could be our bright for 38, which could be our plasma cell population. Coming on to the next plot, which is 34 and 33 gated, shows 34 positive red color cluster, which is our blast. Then
the blasts are abnormally dim for CD34, right?
So next plot, which is 117 and 34, we see that the blasts show variable expression of 117 and a positive for CD34.
Very good. And what do you think this black population is?
So this could be mast cells,
Wonderful.
which are bright for 117.
Here?
Sir, on to the next three plots, we see granulocytes gated. On the first plot, it's 13 and 16 gated, which shows that again the angle between the two arms is reduced, which shows some kind of bridging, which is like the grand show.
So there is nothing really wrong with this plot, all right? It is okay. There is not any great abnormality here. The only abnormality what we are seeing here is this. What is this?
There is a abnormal HLA-DR expression in these.
There is retention of HLA-DR on the granulocytes. And what do we see on the monocytes here?
So on the monocytes, there are mostly mature monocytes which are positive for 14, and there is no like pattern that is being followed. So HLA-DR is underexpressed and downregulated.
So there is a downregulation of HLA-DR on monocytes and increased proportion of
CD117 positive precursor erythroids, which are also positive for 105. So the variable 117 and the positive 105 population of erythroid series is increased.
All right. And what do we see in this plot?
Downregulation of 71, which again shows that there are
an abnormal finding in erythroid cells. All right. So cytogenetics, what does it show? It shows deletion 7q in many of the cells, and you can see even on conventional karyotyping, it's 46XY deletion 7q. Okay. So coming to the NGS findings, would you like to read these, Harshini?
There are two mutations in chromosome 21 and 18, gene mutation U2AF1 and ZBP1. These are point mutations, sir, and the variant allele frequencies 43% and 37% respectively. So it is significant. So
there's nothing more in the NGS. So what is the HEMPAT diagnosis, and does the NGS influence the diagnosis here?
This is MDS with increased blast 2. So the NGS results is U2AF1 mutation is it has high risk of progression to AML. So AML with
excellent. So very good. So you can see that there is a complicated landscape of genomic mutations in MDS, and we know this since many years. And most commonly, mutations include spliceosome factor genes such as SF3B1. All right. So splicing factor mutations are most common. They all have different functions, but it is important to know that only SF3B1 is associated with better prognosis, longer leukemic-free survival, longer event-free survival, and everything else is associated with decreased overall survival. Okay. So SF3B1 is the only one that is associated with better prognosis. Okay. When you look at them, single mutation. So these mutations often occur in a pattern. So patients with complex karyotype often show TP53 mutations. Patients with spliceosome mutations often show U2AF1 and TET2 and SF3B1 mutations, along with these epigenetic modifiers such as DNMT3 and TET2 and so on. And how do we make sense of this? There is a recent paper published in a journal called NEGM Evidence, in which they describe a calculator called as IPSS-M. Now this is a new way to risk stratify MDS, which was previously on IPSS. Now this is IPSS molecular risk, wherein you put in all these features like blast, your hemoglobin, platelet count, neutrophil count, presence of cytogenetic abnormalities, and what mutations you're seeing. So in this patient, we have taken U2AF1 and your ZBP1 mutation, and we click everything else that is here, and it will tell you what is the risk. So this patient has a IPSS risk score that is very high, and an IPSS molecular risk score which is 1.42, which is very high, or which is high. All right. So why it is important to know is that this patient will ask you, what is my outcome? What is my leukemia-free survival? When will what will be how many months I have left to live? So you can see that there is a 50% probability of less than 2 years that he will survive. Okay. So this is a high risk category of MDS. These are known as Kaplan-Meier plots, and this is showing probability to leukemic transformation. This is probability of death. Okay. So in this way, we can prognosticate MDS beyond what is known. So with that, I would like to conclude, and I would hand the mic over back to Dr. Simpy and colleagues. So special thanks to my friends in hematopathology, as well as all the colleagues from Flow Lab and HemePath Lab who came in at last minute to comment on these cases. Thanks so much.
Yes, Dr. Nikhil, there are around 6 questions for you. I'm Dr. Bengal, the moderators here.
Okay.
So, can hypogranularity occur artifactually rather than a feature of dysplasia?
Not that I am aware of. You should be used to seeing your stain properly. As long as the slide is stained properly, it is less common to have this. But once again, it is not one feature that makes this MDS. This has to be noted in the context of what is the clinical history, whether there are any drugs being given, what is the duration of cytopenia, and after ruling out all these reactive changes, you call this MDS. We pathologists have to get out of this mind game that if you see one hypogranular cell, does it mean MDS? No, the entire context of the patient, this clinical picture, and the blood smear has to be taken into account.
The next question is, can organomegaly be seen in MDS with increased blast 2?
So, not commonly. If you have fibrosis in these patients, you can see them. In certain subsets like RARST, you can see organomegaly, which is there, especially splenomegaly, but it would be uncommon.
When do you say megaloblastoid or megaloblastic?
These are semantics. Megaloblastic would be the megaloblastic anemia. Because they resemble those changes in megaloblastic anemia, we say megaloblastoid. Oil means looks like megaloblastic.
Okay, what are the morphological clues for underlying molecular abnormalities?
So only two clues I can think of directly. One is ring sideroblast for SF3B1, which is very, very specific. And the second is those abnormal hypolobate megakaryocytes seen exclusively in isolation. If you see them, then they are monosomy 5, or the 5q syndrome. Other than that, nothing else comes to mind.
How to differentiate normal hypolobated megakaryocyte from dysplastic hypolobated megakaryocyte?
By seeing more and more bone marrows, if you see many bone marrows, you can identify.
MDS with low blast count and SF3B1 mutation. Sorry, I'm sorry, I lost the question, I think. No, that's it, Doctor.
So that's it.
Thank you, Dr. Bindu. Anybody else wants to say anything or ask anything?
And that was a great presentation and discussion, I think.
Thank you very much, Dr. Bindu, Dr. Simpi.
Thank you so much, sir. It was a very informative seminar.
Thank you.